So I want to thank everybody for being here and having me. Again, I'm Emma Barber, and my goal today is to just kind of talk a little bit about my research trajectory and some of the things that I found along the way, specifically focusing on physical activity. So again, some disclosures. Some of the work I'm going to be talking about today is funded by the NIH, NIA. I'm also going to be talking about the Aura Ring, which is a device made by Aura Health Oy. It did not contribute funds to the research, but it did donate the rings. Unrelated to this work, I do have some research grant funding from Eli Lilly, and I'm a consultant for Merck and GSK, again, not related to this. So my overall research goal is to mitigate the toxicity of gynecologic cancer treatment for my patients. I am an MD, and the thing that I really know about is taking care of patients and sort of seeing how they do, and that's really informed, I think, my research agenda and what I'm interested in. So today I'm going to talk about two big categories. The first is predicting adverse events and toxicity. So how do we find the patients that are at increased risk? We're going to talk about physical activity and its relationship to complications, particularly after surgery. And then talk about some work in post-operative monitoring. How could we monitor these patients in the outpatient setting to try to figure out who's going to have these complications and issues? And then a second body of work looking at actually mitigating the toxicity of the cancer therapy. So trying to prevent toxicity using physical activity as our tool. So that's two studies. One is Fit for Surgery, which is a study of physical activity intervention as prehabilitation during neoadjuvant chemotherapy. We just completed this and actually have results. So I was like super excited to add that to my talk. And also Fit for Treatment, which is an ongoing multi-phase optimization study trial of physical activity among patients on active chemotherapy. So I always want to kind of center and bring it back to the patient. What is a patient with gynecologic cancer experiencing? So these patients come to us with pretty large symptom burden in the abdomen, especially with ovarian cancer. We tend to give them about 3 months of chemotherapy to try to shrink the tumors. Then we do this intensive debulking surgery, so this really big incision. We want to remove any cancer that anyone could see or feel. This could include like a colon resection, splenectomy, pretty big surgery. And then we follow that with another 3 months of chemotherapy. And depending on specific risk factors and things, sometimes there might be like 2 years after that of sort of a maintenance treatment or drug. And it's very important that everything in this happens in sequence. If anything kind of goes awry, it can disrupt the next step in the process. And ultimately, this is going to lead to kind of inferior cancer survival. And so specifically, surgery, that thing kind of, sitting right there in the middle, is what tends to sort of upend the apple cart. Adverse events after these large debulking surgeries are associated with increased morbidity, mortality, impaired health-related quality of life. For ovarian cancer debulking, these adverse events, post-op complication rates can be as high as 50% of patients. And when you have those adverse events, it delays the subsequent chemotherapy. And this has been associated in studies with inferior, years later, long-term survival. So how do we figure out, who are the patients that are going to have these issues, so we can try to intervene, help them do better? So traditionally what we've done is we look at preoperatively known factors, right? We're going to put their age into a model, their medical comorbidities, what's their albumin level. We have these national models we can use that are based on national surgical data, and we can actually tell patients what's your specific risk of a postoperative complication. And this can be useful to some degree. We can identify patients, we can, improve our counseling and improve our surgical decision-making. But I think we're limited a little bit by the available data, by what we're putting into the model. Maybe we have their lab work, we have some, diagnosis codes, but we may not be getting kind of a full picture of that patient. And so there's some tools or different things, right, that are emerging that we all know about that might help us get a better picture of that patient. So this is a broad area called mHealth. A lot of you know this, but this is sort of smartphone technology. It could be Bluetooth enabled or not. We can have subjective data, right? A patient responding to a patient-reported outcome, patient-generated pictures, things like that. We can also have sort of objective data or wearable device passively generated data, things like steps, physical activity, your heart rate variability, and sleep. And these are things that can all be sort of passively generated from a device. So sort of thinking of these metrics and these things, these data that we can get about patients, we first wanted to just look and see if there was any signal about kind of preoperative physical activity and subsequent postoperative issues. So we know that this is the case for all kinds of chronic conditions, right? Cancer, cardiovascular disease, these chronic conditions. We know that physical activity is really important. We know that steps can be correlated with mortality. And so we wanted to look directly in our preoperative patients. Can we predict a surgical outcome for GYN cancer patients undergoing surgery? So we leveraged an existing cohort that we had enrolled from 2021 to 2023 that was actually a study looking at sleep. I enrolled 96 patients in an Oura Ring study, so using this Oura Ring device, and we're monitoring sleep, but in this we wanted to do sort of a secondary analysis looking at physical activity. We enrolled 96 people, we had 5 withdraw, and for this analysis we were focused on preoperative activity, so you had to have 3 valid preoperative wear days, which excluded 4 people, so we had 87 patients for our analysis. And we looked at 2 different things, your preoperative MET minutes, averaged, sort of over a week, and also preoperative steps per day. And I just wanted to show this breakdown to kind of give you a flavor that this is not, a really small group, right, that's going to have either very high activity or very low activity. These, sort of activity metrics were pretty distributed throughout our population. We also did not really have differences in the preoperative characteristics by physical activity. So it's not just that, yeah, the physical activity is low, but that's really because these are people that are over 80 and have all these comorbidities and all these other things that, yeah, I already knew they were going to do poorly, So we didn't see, in terms of physical activity levels, differences in age, comorbidities, their CCI, receipt of chemotherapy, minimally invasive or open surgery, the extent, the radicality of the surgery, their length of stay, or whether they had cancer or ultimately were found to have benign disease. We did see that higher BMI and a higher ECOG score was associated with lower MET mins per week and also lower steps per day. So those were associated, but the remainder weren't. The other thing I like to point out with this study, just because it's very interesting to me, is that the average hours of daily wear time preoperatively was like 23. So these patients per day, so 23 hours a day, pretty good in terms of an average. And so these patients really wear these rings relatively well compared to other devices that I've looked at, which to me is interesting. So our outcomes, we looked at any 30-day complication. We had a rate of about 30% in our cohort. And you can see that there was a relatively strong relationship based on physical activity. So their preoperative MET minutes per week. So 50% of the patients who had MET mins under 500 a week had a complication compared to 18-19 if they had higher physical activity. And for steps, 36% complication rate with low steps and 21% with high steps. So we thought, we're seeing a signal here that physical activity and subsequent surgical complication seem to be related. So what did I learn from this study? I think it's feasible to objectively measure physical activity data with these rings. We had really high preoperative wear time. And people who have high preoperative physical activity have fewer subsequent complications. And that's particularly the case with the bigger the surgery is. So like more strong of an association if people have a big laparotomy versus little incision surgery. We also looked a little bit at frailty, so trying to use some other biomarkers to try to, or other aspects of this activity data to predict frailty. So we looked at heart rate variability, which is the variation in beat-to-beat fluctuations, the RR interval. Low heart rate variability is associated with lower resilience, and higher heart rate variability is associated with an ability to adapt to stressors. And physical activity has been associated with improved heart rate variability. We measure the heart rate variability by the RMSSD, which is the root mean square of successive differences. So you can see here, it's basically the square root of these summed sort of RR intervals averaged. We did a chart review. So our definition of frailty was the electronic frailty index, which is a 54-item index. It uses not just sort of ICD-9 codes and things like that, but laboratory values and documentation of functional status. And this was the distribution of not frail, pre-frail, and frail in our population. We did see that the RMSSD differs by frailty. So you can see patients that were frail had a lower RMSSD compared to those that were not frail and pre-frail. This again didn't differ by traditional risk factors, so like cancer, not cancer, and also did not differ too much by age. When we looked at this as sort of a predictor, what was the AUC of the RMSSD for prediction of frailty? We did find that the AUC was 0.85, so a relatively good predictor, and the association with an odds ratio of 0.81. So for every 1 point increase in your RMSSD, your odds of a postoperative, or your odds of frailty decreased by 19%. So in this, we did find that mean heart rate variability is associated with frailty. It is kind of a small sample, but maybe an association that I think requires further research to identify populations that are going to experience complications. And so, frailty is something that we know is really important, but as surgeons, we really don't measure. And so maybe this could be a way to give us more insight. So I hope to this point, at least I've given you some evidence that sort of preoperative physical activity data is associated with postoperative outcomes and might allow us to identify patients that are at increased risk. But we're doing cancer surgery, so we're kind of stuck doing this. We got to do these, we have to do this surgery. Even we look at it and say, hey, this person's going to have a high rate of having an issue. We still are going to have to figure out a way to do that surgery safely. So what about our ability to predict it in real time, to try to predict it before it happens and be able to intervene? That was the next thing I sort of became interested in. And so that gets to this concept of postoperative monitoring. So we do know that monitoring patient-reported outcomes during cancer treatment as patients are on chemotherapy in randomized trials, so you randomize patients to PROs and filling out PROs and not, you can improve your rates of adverse outcomes and actually improve survival in randomized trials. But there are some challenges to using these tools in patients who are having surgery. So 50% of patients actually will not complete them because they don't feel good, right? And the ones that don't feel good are even more likely to have an issue. Those are the people you're trying to find. So the patients with complications are less likely to complete the PROs. And so I sort of was interested in adding mHealth and adding some passively generated data to PROs to try to see if we could create sort of a monitoring program. This was a small pilot study, and I was really just looking at the feasibility of doing this. The secondary objectives were trying to use these PROs and physical activity data from the accelerometer to predict the occurrence of an unscheduled healthcare utilization event on a daily basis. So we're trying to actually predict the day that the patient has some kind of issue that they need us. That could be them calling us and saying, hey, I have all this pain, I need new pain medicine, could be coming to the ER, but basically something that they clinically need from us. And that was kind of the definition of an unscheduled healthcare utilization event. So the monitoring program, this was a prospective cohort single institution study. Our monitoring program consisted of a Fitbit that gave us the output of steps and heart rate and all different types of activity. People had to wear it for at least three days prior to surgery, and then we asked them to wear it for 4 weeks afterwards. We looked at patient-reported outcomes, so physical function, sleep, anxiety, fatigue, pain, all measured by PROMIS, and we did these PROs at baseline and then weeks 1, 2, 3, 4. Our outcomes of interest first were just feasibility. Can people do this after surgery? Will they wear the Fitbits? Will they respond to our surveys? So we defined adherence as completing greater than 75% of the PROs and the Fitbit wearing it for greater than 21 days during the 28-day post-op period. The adverse event prediction, so again, this could be a phone call or a MyChart for a clinical question or issue, unscheduled clinic visits, ER visits, and unscheduled hospital admissions. We created models based on both the patient level, so the kind of current state I mentioned in the very beginning, like who's going to be the person that has the issue, and also on the day level. And so I describe this as like, is today a good day or a bad day? A day that the patient's going to need us in the healthcare system or a day that they're not? And I collaborated with some folks to use all kinds of different models, including some machine learning models to try to identify what's really driving prediction. We looked at feature importance, so what specifically is driving the relationship in the model, and of course, discrimination. So we enrolled 34 people. 31 of them were evaluable. The issues, why did they drop out? Someone lost their phone. Someone didn't undergo the planned surgery that we initially thought they would. So we had 31 evaluable at the end. Age was 58, BMI 30. Our population was around 38% Black race, 12% Hispanic. And you really can see the distribution of all the different cancers that we see, as well as about 24% patients with like a large mass or something that needs surgery. We're not sure if it's cancer yet, and it turned out not to be cancer in the end. 65% of patients had some unscheduled contact with the healthcare system during that postoperative period. So you can see the distribution. The majority of these are these phone calls, and messages with issues, but it also 4 hospitalizations, 7 ER visits. And again, these my charts and phone calls have to be specific to like a clinical issue. So like a wound issue, dehydration, constipation. If they messaged us about their appointment or something, that obviously did not count. So feasibility, the overall wear time for our cohort was around 84%, and 93% of patients wore their device for greater than 75% of the postoperative days. Patients responded to about 80% of the PRO instruments they received, and 83% did the greater than 75% threshold. So it did meet our predefined feasibility criteria endpoints. Then we tried to predict, again, these unscheduled healthcare utilization events. So we used heart rate steps, minutes of physical activity, and then we did patient level predictions. So sort of the previous current state, demographics and labs had an AUC of 0.65. We switched to daily prediction. The wearable alone only had AUC of 0.69, and the wearables with the PROs increased it to 0.77. Feature importance. I use this in addition to sort of what I presented on the previous slide to show that the things that are driving this model are both things from the wearable and also that the patients reported to us. My initial sort of hypothesis going into this was like, I don't know, maybe the surveys are not going to be as useful as the wearable device. Maybe it can replace it, but didn't really seem to look like that. So like things like fatigue and physical function, those are PROs. Then the next one, the active minutes, sedentary minutes, heart rate, those are all from the device. So they're sort of contributing, I think, in different ways and giving us different information about the status of the patients. So overall, this is feasible. Both the PROs and wearable device, it contributes to discrimination. And these, the PROs and wearable devices in this small cohort can predict adverse events on this daily basis. So we've kind of now gotten to the point where I think, physical activity, biometric data, this is associated with frailty, it's associated with adverse events. Maybe we can do it even day of to try to intervene sooner. But the bigger question is this modifiable? Can we actually change those physical activity predictors? Can we help patients move more to help them do better? And so that was then the next sort of step in what we're trying to do. And so again, I always like to kind of center back to the patient. And the point of this slide is, we already talked about what patients go through at diagnosis, right? This is, 2.5 years potentially of pretty intensive treatment. Then also, if patients do experience a cancer recurrence, they're on lifelong chemotherapy, immunotherapy, targeted therapy. And so for a lot of patients, the majority of the time that they're going to spend with us after a cancer diagnosis, they're going to be on active treatment. And so I think, when I think about kind of survivorship research as a clinician, we all say everyone's a survivor from the day they're diagnosed, but sometimes in research protocols, things like, we're going to focus on sleep, we're going to focus on activity. We really only focus on it in patients that are post-treatment. Maybe they have to be 6 months NED, not really in those patients who are actively undergoing the treatment. And for my patients, that's a lot of the time that they're with me, and in some cases that they're with us. And so my interest is really taking that survivorship period and all the great research that's happening there and trying to move it earlier, trying to move it to the times where I see patients experiencing that functional decline and really the toxicity of treatment. So in terms of older patients and older adults in cancer treatment, 60% of GYN cancer patients in the US are over 60. And we do know that older adults have increased toxicity from chemotherapy that's due to age-related changes and other physiologic changes. Cancer treatment itself makes functional decline happen more quickly, increases frailty, and leads to limitations in the ability to perform ADLs. It decreases independence and decreases quality of life. Up to 40% of ovarian cancer patients are designated as frail at diagnosis. And so we take these patients that already 40% are frail at diagnosis, and we add on to that chemotherapy and surgery. And we can even see on scans that clinically significant increases in sarcopenia and decreases in muscle mass happen in the first 3 to 4 cycles of chemo, which is 9 to 12 weeks. So these are vulnerable patients that we're sort of adding a lot of treatment on top of. We do know that physical activity can have benefits even in really small doses. So low levels of physical activity is one of the key hallmarks of frailty. And randomized trials of physical activity in cancer patients have shown that activity is associated with fewer treatment-related side effects, decreased fatigue, and maybe even improved oncologic outcomes. But when I look at those studies, I often wonder if they apply to my patients. And that's because the vast majority of these trials look at breast cancer patients and have a median age of 50 to 55. And my patients, as I said, are often, just by average age of diagnosis older. And obviously they don't have breast cancer. They have sort of abdominal pelvic cancers that I think lead to their own independent kind of symptom profile. Additionally, we don't really know how much activity we need to sort of see benefits. 150 minutes of moderately vigorous physical activity are the recommendations, but I don't know that that's going to be reasonable for someone that just had surgery or is on chemotherapy. We do know that increases in steps of as little as 1,000 steps a day has a mortality benefit in COPD patients. And it's also been associated with improved aging outcomes. So things like grip strength, chair stands, ADLs, and decreased frailty. So that led to the first study, which is Fit for Surgery. This is a pilot study of prehabilitation in the neoadjuvant window of opportunity for older women with gynecologic cancers. So we basically are saying, these patients are having a high risk of adverse events after surgery. They get chemotherapy for 9 to 12 weeks before surgery. And so we want to try to really do everything we can to improve their performance and activity prior to that. This is a pilot study, so we're looking at the feasibility of enrolling these women in a randomized controlled trial of this home-based physical activity prehabilitation program and to estimate the effects of the intervention on frailty, patient-reported outcomes, and surgical outcomes. So this is the Fit for Surgery intervention. What are we doing with these folks? They're getting a home-based program that is patient-tailored goal setting. So their step goals vary based on their symptom burden and patient goals. So basically every day when they wake up, they get a question on their app. They have a Fitbit, they have an app, and the question basically says sort of, how are you feeling today 1 to 5, right? And if they're feeling really well, so their symptom burden is low, and they met their steps the day before, the app will sort of push them to increase their steps. On the other hand, if they're feeling really poorly and they didn't meet their step goal the day before, the app will sort of suggest to them to set a lower goal, decrease their steps for the next day. And this is based on some research that we had that patient symptom burden varies significantly with chemotherapy, right? We tell patients you're going to feel worse, then you feel better, then it's the next cycle kind of thing. And so we wanted something that was going to be responsive and allow them to set an individual goal that is achievable for them. We also paired that with weekly coaching calls. So those calls are really focused on increasing activity and doing SMART goal setting and some motivational interviewing kind of things to help patients move more. This is the schema for the trial. So we enrolled 30, we're aiming to enroll 30 people. We got the baseline measures of frailty, patient-reported outcomes, randomized 2 to 1 to the Fit for Surgery intervention I just talked about, or standard of care education control, which also included a cancer.net app where you can do like symptom reporting, as well as weekly phone calls about important topics for cancer patients that aren't physical activity related. They go on this program for 9 to 12 weeks while they're getting chemotherapy prior to surgery. We repeat the measures, we do the surgery, and then we look at surgical outcomes, repeat measures of frailty and PROs, and also survival outcomes. So we approached 74 patients over like a touch over 2 years. We had 32 patients that consented. We did have 2 that withdrew after enrollment. 1 declined further participation, and 1 had like a change in their biopsy diagnosis. So we actually we randomized 30 people. After randomization, 3 patients withdrew. 2 declined further participation in the study, and 1 elected to enroll in hospice, after a couple cycles of chemotherapy. So we had 27 patients that were evaluable for our primary outcome. The primary outcome was feasibility. So in order for this study to be feasible, we said we had to have 80% of patients evaluable. So 80% of patients had to have like the pre-post assessments, and then 80% adherent in the fit for surgery arm. So we did have 90% evaluable, 2 patients in intervention and 1 in control dropped out. That's those 3 patients I was mentioning after randomization. So we were over our 80% evaluable threshold. We also had pretty high adherence. So patients wore their Fitbit 94% of the days. 97% of the coaching calls were attended by patients. We had 80% engagement with the Fitbit app. So they how many days basically of the total did they open the app, set a goal. And 49% of people met their own step goals. So that was the thing that people were sort of a little bit more optimistic in how many steps they were going to take than it turned out to be. But the thing that I am sort of excited about is in the patients that were in the fit for surgery arm, 75% of patients were actually able to increase their steps. So this is a swimmer's plot here, looking at the change in the average daily steps from week 1 to preoperatively. And so you can see, all the green, those people are increasing their average daily steps. A couple patients did experience declines. These are patients that are, chemo naive and now getting chemotherapy. So, we were sort of thinking even kind of staying steady might be okay. And so to see these increases is something that, at least I'm excited about. The average daily steps increase was between sort of pre-post intervention was 1,800 steps a day. And it was actually statistically significant in sort of a paired t-test over time. These patients are not incredibly active at baseline. So this 1,800 steps is actually a 37% increase in their baseline steps. We tried to look a little bit at the patient-reported outcomes and frailty metrics between the fit for surgery intervention and education control. And so summaries, takeaways from this slide, basically anxiety and pain got better for both groups. Everyone sort of settles in a little bit after cancer diagnosis. So anxiety and pain improved for both groups over time. We did see differences in frailty-related outcomes, though. Patient-reported energy improved in the fit for surgery intervention and not necessarily education control. And maybe unsurprisingly, the frequency of weekly walks almost doubled in the fit for surgery intervention versus no change in the education control. And so that's sort of the preliminary data that we have for fit for surgery that set us up for our subsequent ongoing study, which is fit for treatment. This is now trying to take this concept of physical activity and sort of spread it to not just preoperative chemotherapy, but sort of that long period of time that patients are going to be on maintenance therapy, are going to be on, maybe lifelong immunotherapy or chemotherapy to control their cancer. And the goal with this is really to help people feel better, essentially, and have improved quality of life by increasing their activity. And so we are trying to increase their activity using a MOST clinical trial design. So we're going to try to test 4 components in addition to the baseline component, which is just a Fitbit and the app you can get sort of off the shelf. To that, we're adding a symptom burden tailored app, the one you just saw in Fit for Surgery, an exercise care partner arm, which is sort of a new thing we'll talk about, oncology provider engagement arm, and also coaching. And so we're looking at which of these components most meaningfully contribute to improvements in average daily steps using this factorial clinical trial. We're also going to test how changes in physical activity as measured by steps are associated with the things that we care about. So the patient-reported outcomes, the aging outcomes, and ultimately the cancer outcomes. So who is in our study? This is 192 patients who have a gynecologic cancer. We're going to recruit them over our 5-year study period. We are doing main campus, CDH, Lake Forest, Palos, so all throughout the whole health network. This is something that, you know, patients can sign up for and have everything done kind of remotely. Inclusion is they have to be over 60, have a diagnosis of cancer, and undergoing or planning to undergo a treatment, you know, an active treatment for the full 12-week intervention period. They need to be willing to do an exercise partner, and we only have it in English. Exclusion criteria, we try to keep this incredibly minimal. So this is just meant to basically be like, if it is safe for them to walk, they can be on the study. But if they have uncontrolled angina, they have active brain metastases or some cognitive impairment, they can't interact with the study. Those are really our only exclusion criteria. You know, I think another thing I noticed with some of the physical activity literature is these are really highly selected, motivated patients. We want to see, does this work in everyone? You know, even people that aren't already, you know, have their Apple Watch and all that other stuff. This is our study schema. So we enroll the patients, they undergo baseline assessments, so the primary outcome steps, frailty, functional performance, patient-reported outcomes. They're randomized to their component of interventions. They do 12 weeks of, you know, chemotherapy, immunotherapy, plus their study treatment, 12-week follow-up. Then we stop everything. They get to keep the Fitbit and the commercially available app, and we say, hey, physical activity is good for you, keep it up. And we check on them again in 24 weeks, repeat all our assessments, and we're going to look also at long-term kind of cancer outcomes. This is just a little bit more about the most study design. Some people here may be familiar with it, some maybe not. But this allows us to basically borrow from sort of an engineering design and try to figure out which things are really motivating people to increase their steps. So it's almost like 4 randomized control trials within one. So we can look, you know, at patients randomized to condition 1 through 8, that's the symptom burden app, and compare it to 9 through 16, people who don't have the symptom burden app, to try to estimate the effect of the symptom burden app on increasing steps between those two groups. So we can do that for the symptom burden app, which you already heard about, an exercise partner. So this is basically the patient chooses a partner to participate with them. That person also gets a Fitbit. That person gets regular calls every 3 weeks that are sort of designed around how they can support and help their partner increase their activity. The weekly coaching calls you already heard about. And then also oncology provider engagement. So everyone who gets this component, their Fitbit is hooked up to the EMR, their steps can be viewed in a flow sheet, and 48 hours before any cancer visit, their cancer teams, so their nurse practitioner, nurse, and MD, receive a message that says what their average steps have been over the last 28 days, the percentage of 21 days that they are above 5,000 steps, and also gives like an educational topic, like how does physical activity improve cancer-associated fatigue? This is paired with a message that also goes to the patient, so patient and provider get the same information, and it's designed to sort of prompt discussions between the patient and the provider regarding a specific topic, because we heard, again, in interviews from patients that they really cared what their oncologist thought about their activity. Our assessments, our primary outcome is steps from baseline to week 12. For this study, we are using the actigraph. We are trying to time it in the window of day 8, like after each cycle of infusion, because that week is the time when we think patients will be feeling the same, because there's some cyclic nature to how much activity people have when they're on chemo, and so we're trying to line that up. We do an SPPB that's scheduled with the study team via Zoom, or they can opt to do it in person. And we have patient-reported outcomes, health-related quality of life, pain, sleep, fatigue. We do a freed frailty, and we also have an optional blood draw that we may use to look at biomarkers later. This is our enrollment to date. So we opened in September of 2023. We've approached 137 patients. 53 declined to participate, so 60% actually signed up, which is something I'm excited about. And we do approach literally everyone because it's in my clinic. So a lot of patients are interested in this, which is something that is exciting to me. We've randomized 84. So there are patients that are in that like kind of pre-randomization assessment phases. We have had 2 dropouts, and additionally, there are 39 exercise partners that have been signed up of the 84 that have been randomized. So that blue line represents our target enrollment, and then what we would need to hit if we were going to enroll on time, and the orange is where we are. So we're actually enrolling the study ahead of schedule, which myself personally have never done before. So I'm very excited about that. So overall, I guess one other thing that I would say is it's been very interesting to me seeing the patients on this study. This is like very anecdotal, but we've received a lot of messages from patients, messages from their partners, just about how much they like having a program to participate in and something else to focus on, when they're on treatment. And they feel like it's really sort of helped them like with their mental health and things like that. We just got one of those just a couple days ago. So I think for me, that's been interesting. I didn't necessarily anticipate that, and maybe I should have, but that's been kind of a learning for me. So overall, sort of through these different pilot studies and sort of larger studies, I hope that I've shown you that physical activity metrics from wearable devices are associated with frailty and adverse events. They may provide us with unique and important data that we're not otherwise measuring or aware of for these patients. And physical activity data for patient monitoring is an active area of investigation that many are looking at, sort of beyond me. I do think that the benefits of physical activity are myriad, and the patients who have the highest symptom burden and are actively experiencing functional decline may actually be the people that benefit the most. Physical activity intervention as prehabilitation is feasible in a population of older adults undergoing chemotherapy prior to surgery, and in a small pilot study is associated with improvement in average daily steps. We have ongoing work that we're trying to figure out what is the best way to increase physical activity in these high symptom burden patients that are undergoing active cancer treatment. So I want to thank everyone for their attention. I wanted to put all the faces on the slide of everyone that I collaborate with, research team. I worry I would leave someone off and there would definitely not be enough space. It really takes a village, and there's just so many people that are involved in this and that have helped me along the way. Thank you to all of you.